Today, I'm going to talk to you about palliative care as part of the quality equation in surgery. And part of this discussion will be my journey as a surgeon who's focused on palliative care and geriatrics, and how I've gotten to how I've changed my thinking over time about this. And really, I'm hoping to encourage you to join my fight. My research is really rooted in advocacy. And the fact that I really think that there are ways that we can improve surgical care for seriously ill patients, and I'm very committed to that. So I have no financial disclosures, although I will say that, if anybody out there in Silicon Valley is hearing me, I'm happy to have some. So I don't have any right now. So I think the key takeaways from this talk are that seriously ill patients have surgery, and we'll talk about what serious illness is. That seriously ill patients need supportive and palliative care really no matter where they land. And there's been a lot of focus that seriously ill patients who have cancer need supportive and palliative care, but we have not translated that across the various settings where they receive their care. And a remarkable number of surgical patients do have serious illness. And then the third thing I would say is don't blame humans. And, this is something that I've come to over the decade or so that I've been studying this. And I'll tell you quite frankly that, I really have spent so much time frustrated with other specialists that they're not talking to their patients, that they're not providing palliative care. And what I've realized is that we really don't have systems in place to support individuals. That I really believe that all physicians and clinicians go into this work to do the right thing for our patients. We're all trying our very best, and unfortunately, there are headwinds often in our way. So, as Kristen mentioned, I am a trauma and acute care surgeon. I went into trauma for the same reasons that most people go into trauma. I like adrenaline. I like saving people from the jaws of death. I like taking care of people who are acutely injured and are supposed to get better. I was trained in New York City, or I did my medical school in New York City. And, we had, at the time, there was a lot of gun violence, and I really appreciated the rush of all that. But the fact of the matter is that the population is aging very quickly. Each day, over 10,000 people turn 65. The fastest growing segment of the population is, in fact, the oldest old. And so instead, many of my patients end up looking like this. And this is, in fact, a picture of Arnold Relman, who was a former editor of the New England Journal of Medicine, who fell and sustained intracranial hemorrhage, facial fractures, a cervical fracture. And this is a picture of him in the Mass General ICU, where he was for about 3 months before he found himself in rehab for about 6 months. He wrote about his experience in the New York Times, and then unfortunately died shortly thereafter due to another illness on his 91st birthday. But this is a phenotype that was becoming increasingly familiar to me as a trauma surgeon. And in fact, approximately 40% of trauma patients at this point are, in fact, over the age of 65. And so, what I find is that more and more frequently, palliative care is an important element of my practice. Because patients are, either near the end of life, there's been a change in their healthcare trajectory, and that, they and their families really need an additional layer of support that the healthcare system isn't currently providing them. And so, what does this have to do with surgery and surgeons? I think part of the challenge is that as surgeons, we are really trained to save and extend life, and oftentimes that can be at the expense of quality of life. And as patients are seriously ill, and particularly as they're older, they start to prioritize things differently. And so we need to expand our own thinking in surgery to really capture the needs of a much broader set of patients. And I will say, particularly for the trainees who are in the audience and the medical students, at this point, because of where the population is going, unless you're a pediatric surgeon, you are a geriatric surgeon. And so these things are immediately relevant to you. And so in thinking about how I could care better for my patients, I actually remember the moment that I was attending in the cardiac surgical ICU and was really having significant moral and emotional distress because I felt like I wasn't able to communicate with a family who was clearly suffering because they seemed to understand that their mother was dying, but nobody had really told them very clearly that's what was happening. And part of the challenge is that, the prognostic information that we have is really, and certainly at the time was really inadequate. And that we just weren't trained as surgeons and intensivists to really, have serious illness conversations, to disclose bad news, and really to provide the kind of communication that our patients and their families need. And so it was at that point that I actually decided to get additional training in hospice and palliative medicine. And when I was an acting fellow at Dana-Farber Cancer Institute, I was really shocked to see that the average age of the census on the palliative care service was actually lower than on my trauma service. And that the same frailty and cachexia that I was being trained to manage in cancer patients was actually very relevant to my trauma patients. And that was really what started me in thinking about how I can change systems and structures and do research in palliative care and surgery to try to bring this to our patients. So first, I want to talk about serious illness because this is a concept and a definition that's very familiar to palliative care clinicians and to geriatricians, but may seem a little more amorphous to surgeons. But serious illness is defined as a health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life or excessively strains their caregiver. And the data shows that patients who are seriously ill benefit from palliative care and benefit in all sorts of ways from palliative care, whether it's reduced depression, reduced anxiety. There are even studies that show that palliative treatment in cancer patients can extend life. It improves quality of life. And so these are patients who can benefit from palliative care. And so the palliative care literature and quality measures in palliative care are really directed towards this group of patients, which quite frankly, if you're a vascular surgeon, a cardiac surgeon, a trauma surgeon, a surgical oncologist, in any form, this type of patient is actually very familiar to you. So, these are surgical patients as well. And so palliative care is really a holistic approach to surgical care that defines success from the perspective of the patient and is focused on the patient and family unit. And so the benefits for the patients are improved communication. Sorry, my computer just improved communication, better prognostic understanding, fewer symptoms, better quality of life. But the benefits for the surgeon are often better understanding of what the patient's goals and priorities are, better decision-making with less decisional regret on our part, less conflict among the interdisciplinary team, better patient selection, and better personal connections. And quite honestly, I believe that this is a key to less burnout. I think that, we all went into this because we want the human connection. And so many times that can get lost in these very difficult clinical interactions. And I think in my own experience, practicing palliative care has really brought that to the fore and kept that very central in my own patient-clinician interactions. And I think has really contributed to my professional well-being. So this is a vision of surgical palliative care that was put forth by the American College of Surgeons back in 2005. And this coincided actually with my critical care training and was very informative for me and helped shape my thinking about it. And the leaders at this time and continue to be, quite frankly, are Jeff Dunn and Ann Mosenthal, who contributed to this. And what they said was that surgeons emphasize that control of suffering is of equal importance to curing disease. And that surgeons should lead and advocate for life-affirming, active efforts to relieve the pain and suffering of all individuals with chronic illness and injury, not just restricted to those at the end of life. And I think that this last statement is really critically important because one of the challenges, not just among surgeons, but also among the lay public, is that palliative care is often equated with hospice. But in fact, as more and more patients are living chronically with serious illness, palliative care is also about supportive care and, in fact, survivorship. And it's really how we can maximize the quality of the time that patients have with us. So over the course of this talk, I'm going to introduce you to some composites and some patients that I've cared for who have helped shape my thinking, informed my research questions, and I hope are familiar to many of you. So this is Ramon, who is a 71-year-old man who has metastatic lung cancer. He's currently on his third line of chemotherapy. He has been taking steroids because he has significant bony metastases that have been causing him incredible pain. He's been living at home with his wife and his daughter, but over the past few weeks, he's declined considerably, largely due to pain. He's been immobile, he's become largely bedbound, he's not eating very much, and due to his pain, his steroid dose has increased. I met Ramon in our emergency department when he was tachycardic, had some borderline hypotension, and had a perforated ulcer from his high dose steroids. And so, you know, I'm sitting with him and his family at the bedside. He's in extremis. He's somewhat delirious, unable to participate in the conversation. His wife and his daughter are pleading with me to do everything possible. And I realized as I was talking to them, I really didn't have a lot of information to help me understand what his prognosis was and what things would look like for him with or without surgery. I certainly knew there was an anatomic problem that I could correct. I didn't actually know if this was going to improve his quality of life. And I was very worried that given, you know, his recent decline, that it could in fact mean that he would never leave the hospital if he weren't going to die from surgery. And so, you know, this was a very perplexing problem, and I posed it not only to myself, but to some of my colleagues, and used this patient to help me ask some research questions. So, you know, I worked with Amy Kelly, who's a researcher at Mount Sinai and is expert using the health and retirement study, which I think some of you at Stanford have used as well. This is a longitudinal study that's run by the NIA, interviewing individuals over the age of 50, and it's linked to Medicare data, and it's longitudinal, so the patients are interviewed every 2 years, and so you can use this to understand what their trajectories are. And so we identified a cohort of patients who were over the age of 65 and had emergency laparotomy, and we looked at mortality. And what we found was that for patients who were between the ages of 65 and 74, at 1 year, 23% of them had died. If looking at patients who were 75 to 84, by 1 year, 35% of them had died. And for patients who were over the age of 85, there was 50% 1 year mortality. But what was most surprising to us, and is not reflected in this figure, is that having a surgical complication increased the odds of death more than threefold, and was in fact a greater predictor of death than renal disease, congestive heart failure, and even cancer. And you can imagine in a patient like Ramon, he's at very high risk for complications, and we would even expect that. The other thing that I think this data shows that's so critically important for us to keep in mind is that the mortality really continues after patients leave the hospital. Yes, the slope is most sharp at that 30-day mark. However, the residual mortality continues, and there's significant mortality at 6 months and even out to a year. So this means that the 30-day metrics that we're using are really not necessarily relevant to patients, and that we have to think about how surgical treatment can impact the type of end-of-life care that many of these folks receive. A major concern is that high-intensity care for people at the end of life doesn't necessarily mean better care. A number of papers have shown that for patients with cancer, palliative care and hospice actually, as I mentioned, can confer a survival benefit, but is also associated with less psychological distress and better bereavement outcomes for survivors. So, you know, in thinking about how can we improve care for Ramon, how can we think about palliative care? So one of the things that we did was we did some interviews with 24 acute care surgeons over across the nation, and we asked them about Ramon, and we gave them this same vignette, and we asked them, you know, how would you estimate his survival within 72 hours without an operation? What would you tell his family? And what I want to show you here is that on the y-axis, we have the percent survival estimate. On the x-axis, it's the participant number. But these survival estimates are highly variable. You know, they range from 100% risk of death down to 40% risk of death. There's actually one person, participant number 18, who didn't think that he was likely to die in 72 hours. And so there's a lot of uncertainty here, even among the clinicians who are taking care of patients. We then asked them about Ramon, and we said, well, what would you expect the survival to be if the patient had surgery. And again, here on the y-axis, you can see the time, so days, weeks, months, 6 to 12 months, 1 year, and then the participant number is at the bottom. And again, there's significant variability here. However, most respondents thought that Ramon was likely to die within 6 months, which is consistent with prognostic calculators, et cetera. But it also shows that even with, my apologies, it also shows that even, with surgery, with an expected less than 6 month survival, Ramon is somebody who would be a candidate for hospice. The other thing that I want to impress upon you is that if you're a patient, the prognostic information that you receive is really dependent on who's on call, which is obviously very challenging. So this is something that we need to get better at, is prognosticating and disclosing prognosis to patients and families so they can make good decisions. So thinking about, Ramon, this is somebody who could benefit from palliative care even before he came in with surgery, and then also who would be eligible for hospice even if he had surgery. So that also got me to thinking, well, how many of my patients come in who already would benefit from palliative care, who already need palliative care, whether I operate on them or not, or no matter what their surgical condition might be, because a lot of patients on an acute care surgery service, for example, we don't operate on them. Let's say they have a small bowel obstruction and it's managed medically. So again, collaborating with Amy Kelly and using the health and retirement study, we looked at the burden of palliative care needs among older adults who were having emergency surgery. And this definition of a burden of palliative care needs corresponds with definition of serious illness. And this was previously used in the health and retirement study by Dr. Kelly and others at UCSF. And it includes age. It also includes function. So any needing assistance with any activity of daily living, if they used any helpers for performing activities of daily living, dementia, comorbidity score, if they had a recent history of high healthcare use, and if they had a Lee index greater than 14. And the Lee index is a prognostic indicator, and an index score of greater than 14 suggests that among community dwelling elders, they have a very high risk of mortality within 4 years. And so using this composite definition of a high illness burden, what we found was that in this cohort of just over 400 patients, that almost 2/3 of them actually met the definition for high illness burden and having palliative care needs even before surgery. The other thing I want to impress upon you is looking at this survival analysis. It looks pretty similar to what I showed you previously, which is that if we look at patients who have low illness burden, the mortality at 1 year is somewhere around 23%. That's in the blue line. If we look at patients who have high illness burden, the mortality at 1 year is somewhere around 50%, and that's the red line. And so while age is not completely correlated, the mortality, 1 year mortality for these folks who have high illness burden and who are over the age of 85 is about 50%. So this is information that we can take as we talk to our patients and families and we do care planning. This is Elaine. She is a 68-year-old, I should say, who was recently retired as a high school teacher. She's widowed, but she's remarried. She has 2 children, 5 grandchildren, and she's had ovarian cancer for 5 years and was in remission until recently. She had a surveillance CT that showed progressive peritoneal disease and a partial small bowel obstruction. And she then presents to the emergency department 4 weeks later with intractable nausea and vomiting. And you are asked to see her to consider surgical options, and you look at her CT scan and you see that she has diffuse carcinomatosis and peritoneal disease. You go to meet with the family and they walk in and they say, we're so grateful that you're here because the oncologist told us that you could fix this problem. And one of the things to keep in mind is, what is Elaine's prognosis? And, patients and families make different treatment choices when they understand what their prognosis and their survival would be. The other thing we need to keep in mind is, what are the outcomes that might be most meaningful to Elaine in this situation? In the case of malignant bowel obstruction, palliative goals could include nasogastric tube removal, alleviation of nausea and vomiting, less time in the hospital, and death at home. And so how would surgical treatment or medical treatment be associated with these kinds of outcomes. So we used SEER Medicare data and did a comparative effectiveness study looking at survival, healthcare utilization, and end-of-life care among older adults who had malignancy-associated bowel obstruction. And this was work that I did with my mentee, Liz Lilly, who is actually now doing, she completed her general surgery training with us last year and is now doing a hospice and palliative medicine fellowship at Dana-Farber Cancer Institute, and will go on to do a surgical oncology fellowship at MD Anderson. But she did this while she was doing her postdoctoral fellowship with me. And we did a look back study looking at patients who had died or over the age of 65, had pancreatic or ovarian cancer, and had stage 4 cancer, and had died prior to January 1st, 2013. They had a first admission for malignant bowel obstruction. They underwent one of 3 treatments, either surgery, a venting G-tube, or medical management. Surgical treatment included resection, diversion, and bypass procedures based on claims definitions that we used in prior studies. And then for venting G-tube, procedure codes don't necessarily specify the indication, but we did some preliminary work which helped us designate it by code. We then looked at commonly accepted palliative care outcomes for patients who have cancer that have been endorsed by the National Quality Forum, including time to hospice enrollment, ICU care in the last 30 days of life, and death in an acute care hospital. And among this cohort of over 3,000 patients, the median age was about 76 years. 89% were female because of the high prevalence of ovarian cancer, and 86% of them were white. And what we found was that, not surprisingly, there was better survival in surgical patients. 61% of these patients had medical treatment at their first admission, 27% had surgical, and 12% received a gastrostomy. However, the overall median survival for the entire cohort was about 76 days, which is about 2.5 months. So if you look at that woman in the picture, you may not realize that, but that is the median survival for patients who are presenting with their first admission for a malignant bowel obstruction. And so these types of outcomes are critically important. If we look here at the differences, you can see surgery is in the solid dark line, medical management is in the dotted line, and the venting gastrostomy is in the dashed line. Again, the survival for venting gastrostomy was significantly lower, but again, median survival is less than 3 months. And so then how does end-of-life care differ by treatment? And here, again, we looked at hospice enrollment, ICU days, in hospital death. We looked at surgery, venting gastrostomy, and we use medical care as the reference. And patients who had surgery were less than likely to enroll in hospice, were more likely to be in the ICU in the last 30 days of life. Patients who had venting gastrostomy, conversely, were more likely to enroll in hospice and less likely to be in the hospital or the ICU in the last 30 days of life. Now, you know, there are lots of things that we can't account for using administrative data, like the anatomic issues that would persuade a surgeon to operate versus to not operate. But I think that what this signifies is that there's a bundle of care that patients with venting gastrostomy are receiving that the surgical patients are not. And that, you know, if we modify our care processes, we might see these better outcomes for patients who undergo surgery, which may very well improve their quality of life, should prolong their life if it improves their quality of life. But nonetheless, they're still at very, very high risk of mortality within just 3 months of this hospitalization. So I think, again, there's an opportunity for us to integrate palliative care into the way that we treat our surgical patients. One curiosity that Dr. Lilly and I had was, you know, how do we get some of that granular information to understand what's happening at the bedside? Palliative care, and I'll go into this in more detail, is very poorly coded in administrative data. You know, it's hard. People don't really code for goals of care discussions or code status discussions. And even palliative care doctors tend to bill on symptoms and not necessarily on communication. So it can be hard to get that kind of data. We partnered with a team at Dana-Farber and MIT, Dr. Charlotta Limval, who is also a palliative care physician, and uses natural language processing to identify palliative care in the electronic health record. And so we took a cohort of patients who had advanced pancreatic cancer, and were having palliative procedures at Massachusetts General and Brigham Women's Hospital. And we included over 200 notes. And what we found was that among these patients who were having palliative procedures, were having known palliative procedures, only 13% had goals of care discussions, only 7% had code status discussions during their admission to the hospital, only 10% had palliative care consultations, and only 3% had conversations about hospice. Again, illustrating opportunities for us to improve the palliative care that we deliver to our surgical patients. Next, I want to talk to you about Miriam, who is a composite of a trauma patient that I took care of many years ago. And this is a true story. So this is an 85-year-old woman. Her name was not Miriam, but this is an 85-year-old woman who was functionally independent. She had severe cervical stenosis and was deathly afraid of doctors, surgery, hospital. And she, because of this, she had a deformity of her spine, but she had refused surgery in the past. She was at home cooking dinner for her boyfriend with whom she lived. And for whatever reason, there was a rug right in front of the kitchen sink. She tripped on the rug. She hit her chin on the countertop as she went down. And unfortunately, she suffered a high spinal cord injury. And, you know, when we think about Miriam, you know, she was brought in by BLS. She was brought into our trauma bay. She was rapidly intubated. She was seen immediately by the spine team who expedited surgery for her because her fracture was unstable. She was transferred to the intensive care unit where she received, you know, timely DVT prophylaxis and really state-of-the-art trauma care. And it was clear that Miriam wasn't going to immediately be able to extubate. And so, you know, we made plans for her to be transferred to a facility. But there were some problems with how this was managed. First of all, you know, Miriam's family lived remotely. You know, I guess we're on the East Coast, so the family always lives on the West Coast. I guess for you guys on the West Coast, it's probably the family that's always in Boston or New York. But her family was remote. And so, you know, they didn't have a lot of means. And so they would ask, you know, should we come? Is mom dying? And the information that they got was, no, mom's not dying. She's stable. And, you know, we're going to transfer her to rehab. And I think, you know, those of us who are trauma clinicians on the call know that 85-year-olds with high spinal cord injuries don't rehab. They go to nursing homes. And so, you know, on hospital day number 4, they get a call from the ICU intern who says, you know, it's time for her to get a feeding tube without any real discussion about prognosis, the implications of the feeding tube. They were just told this is really the next step in her journey without really understanding what that would look like. And so even though we provided state-of-the-art trauma care, we didn't really provide the best possible care for Miriam. You know, what are the outcomes that would matter to her? An improved illness experience, a reduced symptom burden, a good death, avoiding non-beneficial treatment, you know, functional independence. This is somebody who, you know, had refused surgery because she was worried about losing her independence. And so here she is, you know, being relegated to a nursing home for the rest of her life. And those things were never really discussed. So even though we provided state-of-the-art trauma care, it's really hard to say that we provided the best possible care for Miriam. And so one of the things that Dr. Lilly and I were curious about is, you know, what is the association between receiving a palliative care consultation in the hospital and post-discharge healthcare utilization for somebody like Miriam. And so, excuse me, we looked at Medicare claims data. We identified a cohort of older trauma patients, and we used Medicare claims for palliative care, which I mentioned are flawed. So take this for what it's worth. But, you know, only 6,000 of those patients received palliative care. And these are all patients who died within 6 months of discharge. So again, this was a look-back study, which honestly has its own methodological challenges, but nonetheless, one of the important things is that there's really no difference in outcome here. So really the independent variables, who's getting palliative care, the dependent variables, who's getting palliative care and who's not. And so you can see here that only about 2% of these patients received palliative care during their hospitalization. But if we look at those who received palliative care, they were less likely to be readmitted to the hospital. The patients who received palliative care are in orange. The patients who didn't, the matched controls, are in gray. They were less likely to be admitted to a long-term care facility. They were less likely to die in institution. They were less likely to have an ICU admission before they died, and they were less likely to receive life-sustaining treatments. And again, these are all patients who died. The outcomes were the same. Now, we know that there are challenges with administrative data, and we can't really attest to what the patient preferences were, which obviously are critical in these decisions. But nonetheless, there is an association between palliative care and reduced healthcare utilization, which is associated with better end-of-life outcomes. So again, an opportunity for us to rethink how we provide our trauma care for patients who are at very high risk of dying. So in thinking about this, I mentioned earlier, don't blame humans. And I want to say that I was thinking, I know we all really want to do the right thing. And I was really influenced by Michael Porter's work, thinking about quality equals value over outcomes that matter to the patient. And palliative care is all about outcomes that matter to the patient. And in surgery, we've traditionally measured morbidity and mortality because we can, not necessarily because we think that those are the outcomes that matter the most all the time, but that's what we measure because we can. And we know that, Medicare, for example, uses 30-day hospital readmission as a marker of quality, again, because it's something that we can measure. But we don't necessarily have data to know if each of those outcomes if each of those readmissions is associated with other outcomes, like perhaps that patient is being readmitted because of caregiver distress, and that the hospital is the best place for them to be. So there's a lot of stuff in these large administrative data sets that we can't really get at. Nonetheless, I'm not the only person who is thinking about this, and I was really pleased to be part of the American College of Surgeons' effort to release palliative care best practice guidelines for the Trauma Quality Improvement Program. And I think we did this somewhere around 2017. And this is really a guidebook for trauma surgeons and trauma clinicians about how to provide palliative care to the increasing number of trauma patients who need it. And my hope is, and often this is the way it goes, that this is a first step to including these practices, which eventually I hope will become standards, and including them in the optimal resource guide that really dictates the resources that hospitals need to be verified trauma programs or ACS verified trauma programs, and really will set the standard for how these things are delivered. But one of the challenges, of course, is how do we know whether or not these practices are being adhered to? As I mentioned, administrative data is flawed, and getting the data from chart review is obviously very, very time, labor, and resource intensive. So, I went back to my colleague, Dr. Limbaugh, and said, it would be great if we could use natural language processing to measure adherence to these best practice guidelines in trauma and see if this is something that would be scalable nationwide to give us a better sense of what's actually happening on the ground. And so I had two mentees, Catherine Lee and Brooks Udelsman, who helped me with this. And it was really interesting what we found. So the aim here was to describe palliative care delivery after moderate to severe trauma. And we compared palliative care delivery identified by natural language processing and administrative coding. We used the trauma registries of Brigham Women's and Mass General, and we identified the codes in electronic health records. We included all adults who had moderate to severe injury. And we used these codes for palliative care. And then for the process measures, again, we went back to goals of care discussions, clarifying code status, consideration for a palliative care consult, and hospice assessment, because these are NQF endorsed measures, as I had mentioned earlier. And so we then looked for phrases in the electronic health record that would match these activities. We had over 2,000 patients in our cohort, and they were very severely injured. Kind of to my point earlier that so many of these patients are trauma patients, even though we looked at all adults, 56% of them were over the age of 65. What we found was that NLP was much more robust in actually capturing these encounters. We found that in over 2,000 encounters, which included over 84,000 notes, 29% of the time NLP picked up some palliative care delivery, whereas administrative coding was only 7%. So we know that we need to be more granular in how we're tracking palliative care delivery. So now that we know we can measure it, you know, it gave us the opportunity to really think about, okay, how can we develop quality indicators for surgical palliative care? How can we define and describe how quality palliative care should be delivered to surgical patients? And so we use the framework set forth by the American College of Surgeons, which includes parameters for the surgical episode, preoperative evaluation, immediate preoperative readiness, intraoperative, postoperative, and post-discharge, and then we also included end-of-life care. And we use this paradigm of, you know, this parallel provision of care, of curative and restorative care, along with palliative care, and then, you know, palliative care becomes more prevalent and prominent as the patient nears the time of death, and then there's bereavement support thereafter. And so the first step that we did was we did an environmental scan looking at broad quality measures across palliative care and surgery. Again, within this rubric that the American College of Surgeons set forth, we identified almost 2,000 indicators, and we found that there were 123 palliative care measures, over 600 surgical measures. There were only 18 overlapping measures, but there were 71 that we thought were potentially adaptable to surgery. The overlapping measures were a little strange. You know, for example, one of the ACOV measures, which is assessment of quality for older adults, said, you know, the percentage of elderly patients with preoperative discussions of goals and treatment preferences, which makes a lot of sense. Another overlapping measure was patient experience with communication after surgery. But, you know, potentially adaptable measures were, you know, the percent of ICU patients with documentation of a family meeting, for example, or the percent of cancer patients who were screened for pain during a cancer-related outpatient visit, or the proportion who died from cancer who were not admitted to hospice. And again, when I say potentially adaptable, these are palliative care measures that are being applied to cancer patients, but not when they have surgery. And we're thinking that they should be applied when they have surgery as well. So we then kind of really embarked on a modified RAND process to develop these quality measures with funding that we received from the National Palliative Care Research Center and the Cambia Health Foundation. We embarked on a systematic review, and this was done by my mentees, Catherine Lee and Claire Sokas, who are both surgical residents currently. We found that there were 26 studies, there were over 200 indicators, 31 of them were specific to surgery, and most of these were focused on communication and end-of-life care, which is fairly limited when we think about the scope of palliative care that also includes, you know, family and bereavement support, symptom management, ethics, and so, you know, we look for opportunity to broaden that. But if we're going to think about how to deliver quality palliative care, one of the challenges for us here is that we have to define what is the denominator. If we go back to that quality equation, there has to be a denominator. And so who are these patients? So if we go back to that first definition that I told you about serious illness, you know, how can we adapt that to surgery? Because most of the work in defining serious ill patients has really been done in medical patients, including cancer, COPD, particularly dementia, and heart failure. And so how does that change with surgery? So we convened a Delphi panel that included experts in palliative care, geriatrics, surgery, quality measurement, nursing, et cetera. It was a broad interdisciplinary panel, and we brought them all to do a Delphi process where we had a number of different surveys, which included defining the population for palliative care, this denominator for serious illness, this denominator, and then also what were the quality indicators. So here I'll share with you, which was a preliminary and modified serious illness definitions presented to this expert advisory panel. And there were some minor changes that we made, but this was based on those same quality standards that we had examined and adapted in our environmental scan and our systematic review. And so, for example, ASA class isn't relevant to medical patients. So this is a new definition that's relevant for surgery. In looking at patients with advanced cancer, stage 3 and 4 solid cancers or hematologic malignancies, and at least one hospitalization in the prior year. Oxygen-dependent pulmonary disease, heart failure diagnosis with any hospitalization or at least 2 ED visits in the past 3 years. This is actually a definition that meets criteria for hospice admission, actually hospice enrollment. Cirrhosis with any Pew class or MELD score. Now, this was interesting because, in serious ill death definitions in medical patients, they tend to consider very end-stage liver disease, but we recognize that surgery has different physiologic demands and puts different patients at risk for, for adverse outcomes. And obviously, we know that liver disease is one of those. And so this part of the definition was adapted specifically for surgery patients. Again, trauma patients are not typically included in the medical definitions. And so, we brought forth that, trauma patients who have severe traumatic brain injury or have a very high AS score or have critical injury, multi-system injury, and require an intensive care unit admission, meet the definition for serious illness and that they have limited life expectancy. It's burdensome, it's difficult for families and patients, also including frailty and nursing home residents, recognizing that that's a specific patient population in surgery. And so, these are the patients that we would include in the denominator. And we did a Medicare analysis and found that when we use the AHRQ definition for major surgery, there are actually over 1 million, it's 1.1 million patients a year who undergo major surgery who meet this criteria. And so, this is not an uncommon problem. And so if we look here, these were some of the indicators that we came up with, this Delphi panel came up with. And here you can see the title and description. I'll highlight that for you in a minute, but then also the ratings for validity and feasibility on a scale of 1 to 9. And so all of these met criteria for validity and feasibility by the RAND criteria, and this has been published in the Annals of Surgery. So I'll give you 2 examples here. One is, having an ICU family meeting, for example. So if a seriously ill patient experiences a postoperative ICU stay greater than 5 days, then a multidisciplinary family meeting should be conducted to discuss prognosis, complications, and anticipated impact on survival, symptoms, functional disability, and potential discharge location. And so all of these things need to be discussed to meet what we would say is the quality measure. This has been adapted from previous ICU literature. Again, it's just, this is applied in the medical ICU and right now not in the surgical ICU. And we're saying we should bring it to surgery as well. Another example is a postoperative palliative symptom assessment. If a surgical procedure is performed with palliative intent and the palliative symptom is not improved after surgery, then an alternative management plan should be offered during the same admission or at the next postoperative visit. And I should say that, as of now, there's still really no way of universally classifying procedures as having palliative intent or not, which creates a whole host of problems with respect to quality measurement, because many of those patients have a limited life expectancy. And so those traditional metrics of 30-day mortality and even complications don't necessarily get at what the intent of the procedure and are really flawed in measuring success at these procedures. And so one thing that we hope that this set of quality measures will kind of bring that to the fore and highlight opportunities to designate procedures as palliative so that we can really understand whether or not they worked. And if they didn't work, what kind of treatment the patients received. One thing that's been very rewarding is work with the American College of Surgeons around this. I think many of you may be aware that the American College of Surgeons came out with geriatric surgery verification standards in 2019. And I was delighted to work with the team who put those together to inform some of the standards around preoperative deliberations and communication before surgery. And so I think this is a really critical an important first step in integrating some of these palliative care standards into quality measurement and practice for surgeons. So, this first one is a discussion of treatment and overall health goals. And I will say that this is, among the first standards that the American College of Surgeons have put forth that are really about decision-making. Recognizing that decision-making is really very complex in many of these patients, and really brings to the fore the elements of what this communication should look like. And so this first standard says, deliberation over surgical decision-making must allow older adults the opportunity to discuss the following with the surgeon: overall health goals, treatment goals, and the anticipated impact of surgical and non-surgical management on function, burden of care, living situation, and survival. And so after the discussion, the surgeon must document the treatment plan and how it's been informed by the shared decision of the patient's goals. Measuring this will be a challenge, but I think that we are up to it, and it will reflect an opportunity for us to make sure that we're really aligning the surgical treatments that we're providing with patient goals and expectations. Another standard in there is about code status and advanced directives, that existing advanced directives have to be reviewed preoperatively by the surgeon, and that a plan must be offered if advanced directives don't exist. That medical proxies have to be identified. Patients lose decision-making capacity routinely around the time of surgery. Who is going to be the representative, and what training does that surrogate need to understand the importance of their role? Again, going back to the standard that I just showed you, life-sustaining treatment discussion for patients with a planned ICU admission. And then there's another standard about life-sustaining treatment discussions and family meetings for patients who have been in the ICU for a period of time. And then there's another standard about reaffirming surgical decision-making. And so my hope is, and it's not just my hope, it's the hope of the American College of Surgeons and others, is that putting structures like this in place will help to facilitate the type of care that I think we all hope to provide to these seriously ill patients. So in summary, I want to say again that seriously ill patients have surgery, that they need supportive and palliative care really no matter where they land, and it's still our responsibility to provide it even in a surgical setting. And don't blame humans. We need to put things in place so that we can all do the right thing.